Thank you. Thank you very much, Laura. Thank you, everybody, for coming for this session, which is very important. As various speakers mentioned, our experience in Ethiopia is great, and transition is one of the areas that we have been working. We'll have another session on transition in the afternoon here, and I hope everybody will be in that session, although we have 3 parallel sessions. But now we hear more from the Ethiopia experience. We have Leulseged Ageze, who is the Chief of Party for the Ethiopia program. It's my pleasure to introduce him because I know Leulseged for long and we have been working with him for the last 13 years, which is long, and we have been part of this health system, health financing process in Ethiopia. And Leulseged will share us the Ethiopia transition experience, and then we have another government person who will tell us through video what we have been doing in Ethiopia. Leulseged, this.
Okay, thank you, Hailu. Good morning, everyone. Yeah, I would like to share what has been happening in Ethiopia over the last 5 years, and especially so on the transition aspect. We understood transition to mean shifting responsibilities to local actors, basically. It is about ensuring ownership of activities by government. And in fact, it also means institutionalization of reforms within the government system. So it all amounts to saying that once the project ends, activity should sustain on their own within the government system. So before I start talking about the reforms per se and the transformation of the transition of reforms over the last several years, I would like to talk about a little bit on the challenges of health financing reforms that drove everything to undertake the reforms that we've been implementing. 3 major challenges. The first one was health was underfinanced. In Ethiopia, health facilities used to run out of budget, basically operational budget, within a matter of 3-4 months. And because they didn't have the right level of allocation from government budget. So they had serious problems in terms of having adequate supplies of drugs, adequate supplies of equipment to provide reasonably quality health care. The second set of problem is related to facility-level decision-making. Facility-level decision-making didn't happen properly in Ethiopia because things were centralized and bureaucratic decision-making was not really helpful to decide on issues of importance at the facility level. So the third set of problem is basically related to out-of-pocket expenditure, which is basically disproportionately impoverishing and catastrophic, which is also inequitable. So to address these challenges, the government of Ethiopia came up with a health financing strategy in 1998, and since then with a series of USAID projects, we're trying to implement activities, and by July 2013, we had to transition from the then health sector financing reform to health finance and governance. So, what has been happening since then? what were the changes? Is there anything better? I think to answer these questions, I can cite two examples. The first one being revenue retention and utilization. What do we mean by revenue retention and utilization? It is a discretion given to health facilities to collect revenues and utilize by having the approval of the governance structure in that facility. The governance structure in that facility being the boards that are supervising and supporting the health facilities. I can probably give you an example, a live example, from one of the hospitals in one of the regions. In those earlier days, Hailu and myself went to that hospital, which is the Brabrahan Hospital. If you think of Ethiopia, and those of you who know Addis might guess where it is, it was north of Addis, 100 kilometers. And we were there to explain to stakeholders the kind of reforms that were to be launched by government. And in that hospital, we met the hospital medical director, whose name is Dr. Fasahat Addes. He went there, explained a lot of problems regarding the hospital. The hospital used to run from adequate supply of essential drugs. The infrastructure was dilapidated, and in fact, the bed occupancy rate was very low. So much so that in that particular day when we were there was no a single patient in the hospital. So the man was very much frustrated. He was desperate enough to look for some kind of assistance from government. And we were trying to explain the components of the reforms, what the reform would bring about, and we were talking about this revenue retention utilization piece. And he promised immediately that if he has opportunity, he will try to change the hospital. Given the smallest amount of resources that he could collect from the hospital, he promised to change the hospital for the better. And in fact, he did. And as a result of that, hospital utilization went up. And in fact, currently, the hospital has got 95% of essential drugs available throughout the year. It did purchase the equipment that were necessary to provide services. It expanded the rooms like the maternity wards and, of course, neonatal intensive care units. And in fact, with the support of the governance board, they did buy residential buildings for the medical doctors, because it was one of the major problems for to retain medical doctors in that particular hospital. What happened was, as a result of that, the hospital changed tremendously. It won 3 trophies from the government as a result of this change. And in fact, personally, Dr. Fasahat Addes was awarded from the federal government and the regional state twice as an outstanding performer. And he ascribed the whole change in that hospital to the implementation of the revenue retention and utilization component of the reform. But generally now, in Ethiopia, we are implementing the reform in more than 3,500 health centers, more than 250 hospitals. And I think the most important thing here is the transition element. Because of the works that we've done, we have the operational manuals, the legal frameworks in place. We did train a lot of people, and we have created a critical mass of specialists that can implement the reform. And as I speak, a number of like 5 out of 9 regions can implement the reforms independently without any support. I said 5 out of 9 regions because there are some developing regions that need some kind of support, probably going forward. I think the second set of example could be the community-based health insurance. You have heard this morning, community-based health insurance is meant to ensure, or seen, at least in our country, as part of ensuring the universal health coverage. In 2008, the government came up with a health insurance strategy, and we piloted in certain districts, and we saw the success in the pilots in terms of increasing health service utilization, in terms of mobilizing more resources for health, in terms of addressing the issue of equity, because we did manage to include more than 7% of the poor in the scheme. So we did implement CBHI in a more aggressive manner after 2013, once we had the evaluation of the pilot in 2013. Again, I can tell you a story in this particular regard. Recently, I was in one of the regions, again, as part of our responsibility to undertake integrated supportive supervision visit. And we met a district community-based health insurance coordinator, and was telling us an interesting story about the wonders that CBHI is really making in the community. A mother of 5 was very sick, and she was advised by the neighbors and relatives to see the nearby health facility, which is basically a health center. She went there. She was examined by the HO, health officer, and because it was beyond his capacity, he had to refer to the nearest hospital, which is in the regional capital. She went there. She got all the treatments, but suddenly she died. She didn't pay anything for her care, but she had to pay about 15,000 Ethiopian birr, roughly $555 out of pocket for some imaging services that she got while she was in the hospital. And luckily, and because she's a member of CBHI, her children were reimbursed that $555, thanks to the CBHI scheme. Although she was not alive, she didn't, transfer liability to her children. So that's the kind of, if you see, important things that are happening while we implement CBHI. It provides protection to the people. It tries to save the family from impoverishment and catastrophic expenditure. So generally, recently, as I speak now, we're expanding to 500 districts in a country where we have 900 plus districts. And about 17 million people are benefiting out of it. And in fact, we are providing financial protection, not only for the 17 million people, for the very poor who need to access from the services. What has changed, really? I think in terms of institutionalization, in terms of transitioning, we did manage to create the capacity by way of putting in place the organizational structure that requires to push the reform forward. The districts do have scheme offices. They have 3 staff. And in fact, we put the legal framework in place, and we have the Ethiopian Health Insurance Agency, an institution which is responsible to spearhead the implementation of health insurance with about 1,000 staff. So that's what we did the last 5-6 years. So my probably message as a summary would be, yes, healthcare financing, including health insurance, is making a difference in the health system of the country. We have tried to institute a system whereby they can work independently going forward once the project ends. And we have shown to the community that, for example, CBHI is not about health only, it is beyond health, because it does a lot of wonders. And the other probably challenging aspect is the capacity building piece. And capacity building is being institutionalized in the government training centers in the university so that government can create local capacity to push the reform forward and make us as a project relevant going forward. Thank you very much.
Thank you very much, Leulseged. That was a wonderful experience sharing. And I think it's good also to hear from our government counterparts. We're hoping to have a government representative here, but unfortunately the person that we reached was not able to make it. But fortunately we have a video, a short video, which we can see what he said about the program and the support and the transition and the institutionalization. Laura.
I'm very, very grateful to be part of this program, but I felt sorry that I couldn't make to the end of program. If you come to my bureau this time, we established a resource mobilization unit and grant management unit by ourselves. The establishment of Ethiopian Health Insurance Agency is also something which became effective after the introduction of this healthcare financing strategy. The government has clearly noted the need and importance of supporting the area. Initially, it was considered as a political agenda and left aside. We are at the page to own the program by ourselves. We have all the proclamations, all the regulations, and manuals in place. It was a government program supported by a partner, so it will stay the government program. In all days, our national health account showed close to 50% of our health finance was financed from overseas development agencies. Now we are trying to finance by domestic resources. We need to be much better than today. We started the journey. I'm very optimistic that we can make to the point of universal healthcare coverage. You have to commit everything that you have, including your time, including your finance, including your energy. During our time, I feel we saved many lives, and every life matters, every life counts. Health service utilization matters at all population level, but significantly the maternal and child health service improvement was one of the examples I usually cite. We achieved the Millennium Development Goal ahead of time on child mortality, and we are on the way to attain the set target on reducing maternal mortality. The reason why I'm listing all this is through the collaborative effort of all, including the people of America, USAID as an institution, and individual contribution from all assigned officials as well as employees working in this HSFR, HFG, USAID, Federal Ministry of Health, regional health bureaus, health facilities. I'm also thanking my health professionals for the success of this program. Though it is ending now, I feel we'll together make it to a better level.
Thank you. This person started as a medical practitioner from a hospital. The story that Leulseged told you from one hospital applies to another hospital that he worked for. It's another part of the region. He led the Ethiopian Health Insurance Agency at the beginning. He worked in different capacities in the ministry. He was a deputy, head of one of the largest regions, the city, the Addis Ababa City Administration. And now he is the deputy health bureau head of the largest region in the country, which is Oromia. So to hear from him means he has all the story from the medical practice to leading government institutions. So this is what the team has been doing on the ground. We have few minutes, I think about 15 minutes or so for a question and answer, and Leulseged is available for any question, and you can raise any question. I think we have mics. Question? No, he's not. Here for Catherine. Stand up and tell us who you are.
Okay, Hailu. I'm Catherine Connor. Your deputy director. I feel like you're saying that user fees are good. You know, the story of retaining user fee revenue being the way that hospital went from being empty to winning awards. So, and of course, user fees don't have such a great reputation. So how, what did you do to protect poor people from user fees?
Another question? Or maybe we can react. Leulseged can react.
Yeah, I think, Catherine, you rightly said, user fees are not that good. But in a country like Ethiopia, unless you have the means from elsewhere, there is no any option than utilizing the user fees. So the initial healthcare finance strategy was stating that this has to be turned into a revenue for the health facilities rather than remitting it to the national coffer. Okay. And then the second generation comes, or the second wave of reforms come, which is CBHI. You turn the user fees into some kind of prepayment mechanism. In doing so, those who can afford to pay in the informal sector can pay a little amount, a reasonable amount, but the poor are basically covered by the government. So I think that's what it is. I remember, again, in the good old days, experts came from, I think it was from London, and they were, talking about the user fees, to remove them and things like that. And we asked them whether, by then Tony Blair was the prime minister, would he give us something? Otherwise, there is no any luxury to remove. But at the same time, the user fees it's really not that significant, although still they could be prohibitive for those who cannot afford to pay, definitely. So I think we're changing the scenario by introducing the prepayment mechanism.
Yeah, and another intervention we have is until all districts are covered through CBHI, there is another program called FEWEVER, which is a government protection mechanism for the poor. So poor are identified and financed through the government system, and once CBHIs are launched in each district, they are covered through targeted subsidy, again, government contribution on behalf of the poor segment of the population. Another question? At the back.
Nancy Harris from JSI. fantastic work. I am wondering how the government is monitoring equity, particularly equity vis-a-vis some of the minorities, such as pastoralists, who tend to get overlooked in some of these schemes.
Okay. The pastoralist issue. I think Leulseged mentioned the 5 regions in the 2 administrations. That accounts around 80% of the population and more than 80% of the service. But as you rightly mentioned, the pastoralists are behind both in accessing service and also in getting financial protection. Maybe Leulseged can give us more insight what we are doing in that area.
Yeah, I think one of the things would be the reform that Hailu was trying to explain. The fee-over system is there. And we have yet to start the community-based health insurance in the pastoral regions for 2 reasons. One, there is a gap in knowledge. And we're trying to sort of develop a prototype, and we want to work on it going forward. Although we are ending anytime soon, like in September. So that has been understood by government. The other important thing is, in the pastoral areas, as you rightly said, there is no equity in service, accessing services. But as part of the health sector transformation plan, the government tries to address the issue of equity, because equity being one of the transformation agenda of the government, tries to address in these pastoral regions, or what we call developing regions. Try to introduce the kind of service provision modality that's suited to the interests of the pastoralists. So I think the government is trying to work on it. And in fact, as part of the healthcare financing and governance activities, we are trying to work on the waiver system, and still we are sort of struggling with introducing the community-based health insurance system that probably suits the pastoral areas.
Gina.
Hi, Gina Holtz from HFG. Thank you, Leulseged and Hailu. I just wonder, community-based health insurance is a term that means oftentimes to people, it refers to small private schemes. Could you elaborate on what CBHI means in the Ethiopian context and what's different about it, and what can Ethiopia teach other countries that are thinking about community-based health insurance initiatives?
Yeah, Gina, I think that's an interesting question, honestly, because every time I go to conferences and some meetings, that are the kind of questions that have been asked. Probably there are colleagues who could answer this question much better than I do, but the experience in West Africa has been like micro insurance, where we have 1,000 people or 500 people and what have you. But the case of Ethiopia is such that it is a community movement where, if you go to a typical village where we have, for example, 1,000 households, they'll decide to join the scheme, and then with series of mobilization, sensitization, and awareness creation, a number of them would join into the scheme. So, one, it is a community movement, and secondly, it is actually supported by government. Government plays a major role. 2 things. One, in terms of providing what we call general subsidy for the schemes. The federal government provides general subsidy for the schemes, like to the tune of 10%. And there is also what we call targeted subsidy for the very poor, which is being allocated from the regional government and the woreda or district administrations. So basically, CBHI in Ethiopia is, a joint sort of undertaking between government and the communities. Not only in terms of financing, but in terms of governance also. Communities are represented there, but there are also government salaried employees that undertake community-based insurance. So, if there is anything that we can teach the rest of the world when it comes to community-based insurance, definitely government ownership, as I said before, is very critical. And in fact, still we are working on that front also, because now the coverage is about, 44 to 50%. It has to go to 100% definitely, because those people who are eligible to be members of CBHI or community-based insurance should come or should join the schemes. So I think the answer to you, probably, Gina, is that it is both a government undertaking, it is the collaboration between community and the government that actually spearheads the community-based insurance movement in Ethiopia.
Thank you, Leulseged. I think to add a couple of things. One, it is part of the broader health financing policy framework. So it's designed as a policy, as one of the interventions, and eventually is to have a national health insurance which will merge both formal and informal sector in the long term. And the other one is the magnitude. The pool is not as small as the schemes that you know in other countries, in some of the West African countries. Damas we can tell you a lot. It's a population size of 100,000 each district, which is a relatively large pool. And that is 44% what Leulseged is telling us of the 100,000, which is a relatively larger pool compared to other small fragmented schemes. I see hands, Jody.
Yeah.
Of course, I have to give that chance.
Hi, I'm Jody Charles from USAID. So I really appreciate your discussion about how this is not sort of just a micro insurance scheme, that it really is part of a community movement, and it's linked, it links the community to the national and up and back. A lot of the work that HFG has done as Bob Freit talked about, has been working with the financing and integrating the critical governance structures as well. So I'm wondering if you can elaborate a little bit on the governance structures that are also in place to help ensure things like equity and quality and effective coverage. Thank you.
Thank you, Jody.
Yeah. Okay. I think, again, Jody, is an interesting question. How the governance structure comes in. If you take, for example, CBHI schemes do have governance boards in the districts. That's one thing, where communities are represented, and of course, government officials are also part of the member. And there is also a governance body, which is a General Assembly, where government and communities are represented. To give more weight to community representation, in fact, the General Assembly has a lot of people. And in that, a number of critical decisions are made, including, for example, the amount of, if you like, contributions that should be made by household. They go to the extent of deciding on that. At the same time, they look into, the audit reports, the performance over the last 1 year. So governance comes into play. Aside from that, the boards basically do have what they call boards facility community interface, where they play, like a catalytic role. The boards play a catalytic role. The communities would come, facilities would be there, reports would be presented, and all sorts of complaints could come from the communities, and sometimes people are fired right there, in some cases. At least I know two cases. So that's how the communities are sort of being empowered as part of the governance structure. And in fact, going forward, that is an area that we need, someone has to work a bit more, ensuring that the communities are really represented quite well. Sometimes, in the name of the communities, you might find some government functionaries. So whenever we had discussions at the mission level, for example, USAID mission in Ethiopia, they want us to make sure that there is one representation of women, and secondly, make sure that the representations are not from government offices. They should be pure, local community representatives.
So I think another thing that Leulseged mentioned earlier is the facility level governance also. Yeah. In facility level governing board, communities are represented. So it is the two governing bodies, the scheme governing body and the facility governing bodies are also interacting each other. In both cases, communities are represented.
Yeah, true.
Let me give a chance for the other guy.
Good morning. My name is Paul Crystal from the U.S. Pharmacopoeia Convention. And first and foremost, congratulations.
Thanks.
You mentioned before that those who are eligible need to come. And we often have this attitude that if we build it, they will come. But you've also mentioned this as a community movement, and I wanted to learn a little bit more about what it takes after you've built something on the system side to gain the engagement and participation of beneficiaries. You're at 50% right now, and you said you want to get to 100%. Am I asking the right question as we're looking at that next 50%, or are there other more important questions to ask? Thank you.
Yeah, I think, again, challenging question, I have to admit, because these things are not that rosy. Government has to be committed, as I said before. And if you look at districts where the government people are very much committed, you see like 100% coverage. But in districts where there's a bit lags and they take time for some other things rather than mobilizing the community, it tends to be like 30%, 35%, and what have you. So it all amounts to having the right commitment from government people, basically. And on top of that, I think when we have discussions with communities, what they tell us that it is an interesting program. Definitely, because the story that I told you was like a mobilization material, because it did make a tremendous impact on the community. They value the fact that debt was not transferred to her children, 5 children. We didn't have the means to pay for. But at the same time, we couldn't have the kind of mobilization, sensitization, effort that is required at a country level. You know what I mean? It's a country of 100 million. It requires a lot of mobilization. It requires a lot of sensitization. Although the communities understand what it is, they need to being sensitized, mobilized, so that they can engage and, in fact, sustain. It should be automatic at some point, right? If it is an insurance, it has to be automatic. Because it's a community thing, because it is not relatively matured, I think we're sort of facing some problems. You find some dropouts. In fact, the re-enrollment ratio currently is about 75%. So I think that it has to go to 90-95%. So I think it's a bit of a challenge, but still we're working both on the communities front and at the same time with the government.
I think we have to wrap up, unfortunately. It would have been a very good session to have it for a full day, but unfortunately we have to end it here. Thank you, everybody.
Thank you so much. Yeah, thanks.